of diabetes around the world is overwhelming. According to the International Diabetic Federation, based on the worldwide prevalence of diabetes mellitus, the per region prevalence of diabetes mellitus in 2017 and the projected prevalence in 2045. Diabetes mellitus has reached pandemic state and should be considered a global emergency. If you look at the slide, every 6 seconds, a person dies of diabetes, and in the same 6 seconds, 2 people develop diabetes mellitus. The same thing we are repeating. The idea why International Diabetic Federation is repeating is to emphasize the fact that among the non-communicable diseases, diabetes mellitus is reaching pandemic proportions and it needs medical attention. Hence, medical professionals should be aware of this condition and be ready to tackle this pandemic. Asia is considered the global epicenter of diabetes. Why? As it accounts for nearly 60% of the world's diabetic population. What could be the possible reasons for this explosive increase in diabetes prevalence in Asia? The answer is the rapid rise in the prevalence of diabetes mellitus in Asia could be attributed to rapid economic development and urbanization, leading to changes in nutritional status and changes in lifestyle. You remember, as you urbanize, as you become more modernized, our lifestyle changes. Because of our lifestyle changes, our nutritional status also changes. We start eating hotel food and junk food instead of the healthy home-cooked food. It is important to note that in Asians, the diabetes mellitus develops at a much younger age and at a lower degree of obesity as compared to the Western population. This is very significant and we must understand this. The same thing is repeated in a graphic form here. Here we have clearly explained rapid economic development and urbanization, change in the diet regime, and change in the lifestyles. Here is the data burden due to diabetes across India. Mohan et al., the pioneers in diabetes management, they mention diabetes complications. As mentioned here, coronary artery disease, you find the urban population is more affected. Peripheral vascular disease, again the urban population is more affected. Retinopathy, here rural population is more affected because they don't seek medical help. Nephropathy, urban population is more. Again, neuropathy, you find more in rural population because they don't go to the doctor at the initial stages. But we have one more important complication of diabetes, which I'll be mentioning to you in the next few slides. Namely, sexual dysfunctions. Sexual dysfunctions in diabetes, which occur in the male, or erectile dysfunction, premature ejaculation, retrograde ejaculation, painful intercourse or dyspareunia. The sexual dysfunction which occur in the female are orgasmic dysfunction and dyspareunia. To tell you the truth, the fact is that very little work has been done as far as the sexual dysfunction in female diabetics. So our knowledge is also not very comprehensive as far as female diabetics are concerned. Erectile dysfunction is a common problem amongst men who have diabetes. It affects 35 to 75% of the male diabetics. According to the British Journal of Diabetes, up to 75% of men suffering from diabetes will experience some degree of erectile dysfunction over the course of their lifetime. Men who have diabetes are thought to develop erectile dysfunction 10 to 15 years earlier than men who do not have this disease. Both type 1 and type 2 diabetes are associated with an increased risk of erectile dysfunction, which is reported to occur in 50% or more of men with diabetes worldwide. In the Massachusetts male aging study, one of the longest longitudinal male aging study, diabetic men showed a threefold probability of having erectile dysfunction when compared to men without diabetes. According to Data Statistical Manual of the American Psychiatric Society, edition 5, the criteria for erectile dysfunction is twofold. In criteria A, at least one of the three following symptoms must be experienced on almost all or all occasions of sexual activity. What are three symptoms? Marked difficulty in obtaining an erection during sexual activity, marked difficulty in maintaining an erection until the completion of sexual activity, marked decrease in the rigidity of the erection. This is criteria A. In criterion B, these above mentioned symptoms should have persisted at least for a minimum period of 6 months. Only then you can dub a person as having erectile dysfunction. Now at a molecular level, let us see what happens to a person who has got erectile dysfunction. Now, sexual arousal triggers the release of nitric oxide into cavernosal tissues. Nitric oxide is synthesized from L-arginine by nitric oxide synthase, endothelial nitric oxide synthase. This nitric oxide stimulates the enzyme guanylate cyclase to convert cavernosal GTP, that is gynosine triphosphate, into cyclic GMP or monophosphate. It is the cyclic GMP that relaxes the corpus cavernosum smooth muscles, thereby producing an erection. But as soon as cyclic GMP is produced, our body produces phosphodiesterase type 5. There are 11 families of phosphodiesterases. Phosphodiesterase type 5 is specific to cavernosal tissue. This phosphodiesterase type 5 catabolizes cyclic GMP into inactive 5-GMP. In other words, the duration or available duration and the action of cyclic GMP is short-lived. So erection comes back to baseline. When you give any of these PDE5 inhibitors,